Welcome to Module 4, Nursing Practice, Legal and Ethical Considerations, Palliative and End-of-Life Care. So in this module today, we are going to talk about the critical aspects of nursing practice that are essential for providing high-quality, compassionate care in the critical care environment. Our objectives include identifying the key areas of concern for critical care nurses, such as patient safety, ethical dilemmas, and effective communication. We will also explore the history of critical care nursing and the impact of professional organizations like the American Association of Critical Care Nurses, the Society of Critical Care Medicine, the Emergency Nurses Association. Additionally, we will analyze the ethical principles that guide our practice and examine the decision-making process involved in challenging scenarios in the clinical setting. So by the end of the module, you will have a better understanding, hopefully, of the legal and ethical considerations that are important for critical care nurses and emergency nurses, as well as some strategies for supporting patients and their families. So challenge question number 1. Read it, pause, make your decision, and we will come back to it later. So a critical care nurse is caring for a patient who has just been admitted to the ICU with severe sepsis. Which action should the nurse prioritize to ensure patient safety is in accordance with the Joint Commission's National Patient Safety Goals? A, initiate enteral feedings with 24 hours of admission. B, perform a complete medication reconciliation upon admission. C, place the patient on contact precautions immediately. Or D, conduct a thorough pain assessment using a standardized pain scale. Hopefully, you will have a little bit of familiarity already with the National Patient Safety Goals, but if you don't, stay tuned and hopefully you'll be able to answer it by the end of this lecture. So, in the critical care setting, nurses are on the front lines of managing high stakes, sometimes super stressful situations. One of the biggest areas of concern is patient safety, which involves maintaining high standards of care to prevent errors and ensure positive outcomes for our patients. Oftentimes, though, there's going to be ethical dilemmas that are going to come up. And some of those are going to be surrounded like end-of-life care, and we'll go into a little bit more of that later. And you really do need a deep understanding of ethical principles like autonomy and beneficence to be able to mitigate and go through these challenging times, okay? You also need to be able to manage stress and prevent burnout because those greatly affect critical care nurses. They affect all nurses, but especially in critical care settings when people's lives are like literally in your hands. You also need to pay attention to that there's rapid integration of technology into patient care. And so things are always changing. And this is going to bring new opportunities and challenges as well, okay? So it's important for nurses to stay updated on all the best practices. So we talk about professionalism, and so it's important that, and this is kind of like a hodgepodge of topics, but this all kind of falls under the big umbrella of being a professional nurse. So understanding the history of critical care and critical care nurses is going to help you guys appreciate the evolution of how the critical nurse's role has developed over the years and how it's come into how we practice today. So critical care units, as you know them today, they all started to take shape in like the 1950s-ish. So these came about when we had technology basically and advanced monitoring come about. And so we were able to monitor our patients better. Before this time, we didn't really have electronic monitoring and things. So how you did the best you could as a nurse. We had these big wards, but when we started getting these more advanced technologies, we were able to better and more closely monitor patients. And so then we decided that we needed to put all of the super sick patients that need close monitoring in one area. And that's how kind of ICUs came about. Emergency departments, though, they've been around forever, but it not always in the same context that you see today. There was always just an area where you entered the hospital and they would just stabilize you and then they would admit you upstairs. But there used to be hospitals that didn't have emergency rooms. And the only way that you got admitted is if your primary doctor admitted you from their office. So there's that too. So these advances that I was just talking about, basically they brought about shifts in our roles as a nurse. So like it kind of developed. So nurses didn't used to do the monitoring. That was kind of more the doctor's role, and things kind of trickled down, and they've expanded the nurse's role over the year. So from more just bedside hands-on care to actual like patient advocacy, decision making, and leadership. So there's also been some significant legislative changes in both the state level and the national level, federal level, that have enacted and been able to expand our role. Or a lot of times you hear nurses say the scope of practice. Okay. So these have allowed nurses to actually do more and more autonomy in certain places. And we can also talk about advanced practice nurses. So they have a role now that they didn't have 30, 40 years ago in like critical care settings as well. There's critical care, like acute care nurse practitioners that work in ICUs. And you also have an emergency nurse practitioners that work in the emergency department. So they become providers and they work alongside us as bedside nurses, but they are more on the provider level. So now let's talk about some professional organizations that have to do with critical care. So there's two big ones. There's the American Association of Critical Care Nurses, and there's also the Emergency Nurses Association. And talk a little bit more about AACN, but this organization is dedicated to advancing critical care nursing in general. Okay. Its mission is to support nurses in providing the best possible care to acute and critically ill patients. The AACN promotes core values. And so the ones that they really push are integrity, inclusion, and innovation. And that all guides their practice. Okay. So one of the key benefits of being involved with AACN is access to resources and that support your professional development, including guidelines, continuing education, and certification opportunities. Specific to AACN is the CCRN. We'll talk more about that in a minute. That's the critical care nurse certification. And if you have a CCRN, that means that you have demonstrated expertise and commitment to the field of critical care nursing. And that greatly enhances your credibility with other people, but it also enhances your confidence in being able to just deliver high quality care. Emergency Nurses Association, on the other hand, very similar to AACN and all the other professional organizations, they are promoting emergency nurses in across the world. Obviously, these both actually. So the first one's American Association. Emergency Nurses Association is definitely global. They are some of their biggest mission values that ENA is pushing is patient advocacy and also safety, but safety as well as the providers. Professional organizations are really what is behind so much of legislative changes. In the state of Texas, ENA was the big driving force. They did collaborate with some other professional organizations and groups, but ENA was the driving force between getting legislation passed that protects that assaulting a healthcare worker is considered the second time you do it, it's a felony. The first time it's still a misdemeanor, but it increased the punishment for being found. And it also helped define what assaulting a healthcare worker was before. So there's actually increased, just if you go out and just assault somebody on the street, there's just your normal like level punishment and normal charges that are get brought against you. But if you assault a healthcare worker, it's an increased punishment and increased because it's a big deal. It's kind of like how they have an increased deal for like assaulting a peace officer. So healthcare workers got that passed, but ENA was a driving force behind that. So more about kind of critical care. So, some different associations that support critical care nurses. So remember, it's a team effort when you're in the ICU. It's not just nurses taking care of. They're in ICU and the ER to that extent. So these are the two areas where you actually have providers present 24/7. You will always have an emergency room physician there. And in the ICU, you have what we call intensivists, or sometimes they are doctors. There are some outlying ICUs that may not have an MDDO present 24 hours a day, 7 days a week, but they will have an advanced practice nurse that's there. And then the ICU doctor is on call and that can get there within 30 minutes should they be. But most ICUs have an intensivist there 24/7. It just depends. But all ERs have emergency room physicians available 24/7, which is really nice as a nurse to always have your provider there. You don't have to like call and wait for somebody to get orders if you need something for your patients. Pretty good. So anyways, So, one of the organizations that specifically for the ICU is the Society of Critical Care Medicine. They emphasize the value of collaborative practice, bringing together physicians, nurses, pharmacists, and other professionals. And they all come together, they share their knowledge, and they help write policies. They help do guidelines for what should and shouldn't be done in the ER and how to, like ICU, how we should, protocols for taking care of different types and managing different types of patient populations and disease processes. So, now, what is the value of certification in critical care nursing? I'm just going to talk in general about the value of certification everywhere. You guys, this is so important. Once you get your RN, you're like, yay, I have an RN. I don't need anything else. Oh, but your learning never stops. So do you have to get certified as a nurse? No. Should you get certified as a nurse? Yes. Do most nurses get certified? No. I will tell you though, if you go out and get certified in your area of expertise, clinical practice, it will set you apart from everybody else. You are more desired for getting promoted. You are more desired for getting another job if you want to go someplace else. It is a minimum requirement in a lot of places to even teach. So, like I personally I'm a CEN, but I've been a CPE and I just let it lapse in the past. These certifications, it's basically NCLEX 2.0 in your specialty area. So it is like if you wanted to become a CEN, a certified emergency nurse, you are going to be taking very high level. It's basically this class on steroids, but specific to the emergency department. And it's a very intense test. The certification is good for 4 years. You can renew by continuing education credits or by taking the test again. But every 2 recertifications, you have to take the test. So every 8 years, you're going to have to retake the test to prove that you are still smart and competent in that clinical setting with all the different things that you can be exposed to. CCRN, I have heard. I'm not a CCRN. That's the one for the ICU. It is one of the hardest tests that you can take. But there's certifications all over. You can be a certified pediatric nurse. You can be a certified med-surg nurse, a certified oncology nurse. I mean, there's all sorts of certifications, but it's just a big deal if you get it. And I know you guys right now, you're just focused on that RN, but I would highly encourage you guys to think about whatever area you want to go into as a nurse. Look up whatever the certification is for that area and set a goal of at the end of 2 years of practice that you are certified. I mean, some people can take it at the end of 1 year, but most people recommend 2 years of practicing in an area before you even attempt to take a certification test. It can be really challenging and hard when you have no experience to take some of these exams, but go you if you want to do it early. But I have some of the certifications that kind of revolve around critical care nursing. So obviously CCRN, CEN is just a certified emergency nurse. That means you're just kind of like any kind of emergency, but there is one specific for pediatric emergency. That's actually the first certification I got because I started off in peds and then I went to CEN and then it was like renewing. It was just a lot. So I let the CPEN kind of fall off and I just kept my CEN. There's also certified flight registered nurse. That's for like flight nursing. Certified post anesthesia nurse. This is for like PACU nursing, which that is definitely critical care. I mean, like fresh hearts open post-op surgeries. They're still intubated, possibly on pressors and drips and stuff. So that's definitely critical care. And then obviously CCRN, but there are some others. There's like certified trauma nurse, and I mean there's a whole bunch of others. But the big ones I will tell you in the emergency department is just your CEN, and the big one for ICU is CCRN. But I encourage all you guys to do it. And one of the cool perks is that there's a special day just for you. March 19th, every day is Certified Nurses Day. So if you are certified in any area, it's like a big day. Most hospitals celebrate you, give you some like hospital swag. You probably get something like free lunch, something, I don't know, whatever. It's probably just pizza, but whatever. But it's a big deal. So I encourage you guys to go get certified at some point in your career. Tidbit, hint, when you are applying for a job and going through interviews, they love to ask, what are some short and long-term goals? This would be a great thing to add to an interview question. Like some of my short-term goals in like the next 2 to 3 years, I would love to become certified in fill the blank. That shows that you want to do more than just the bare minimum. It shows that you want to constantly grow and you have a commitment to like learning and all those kind of things. It's also super impressive to managers that are like looking to hire somebody that stands out from the crowd. Just big hint there. Okay, so AACN, Standards of Professional Performance. Okay, these are standards that guide acute and critical care nurses in delivering high quality patient care. These standards emphasize the importance of evaluating and improving the quality of care provided, which is integral to professional practice. So, continuous education and maintaining competence is so important, as basically healthcare just keeps rapidly changing, and the demands of staying up to date with knowledge and skills just keep increasing as well. So, it's important to collaborate with other people, other groups, and that's kind of one of the things that AACN stands for. And enhancing teamwork, ethics are also super important, and AACN definitely promotes ethics and the value of assessing and coming up with formalized plans and what not just what you as a nurse stands for, but your organization stands for. And then also leadership and professional practice environment. What I mean by that is creating a supportive professional environment is so, so important for empowering nurses and enhancing our job satisfaction overall, which then leads to better patient care and better patient outcomes. So have you guys heard of QSIN yet? If you haven't, I'm sad, but you should know QSIN. QSIN's another one of the many things that organizations it's kind of like, it's just the standards that we use. So QSIN, what it stands for is the Quality and Safety Education for Nurses, QSIN. It's an institute, okay? And it's an initiative that was a collaborative effort of all these organizations came together and like super prominent people in the nursing world. And they came together to outline 6 core competencies that are important for nurses to focus on and implement in their everyday lives. Okay, so QSIN is one of those things that we are judged on in every hospital organization. You should always know what your QSIN standards are. If you ever go into management and leadership, you are going to have to know these. You're probably going to have to track data on these. Okay, just know QSIN is an important thing. So some of the competencies is that your organization and your nursing workforce and everything are providing these things and are creating environments for these things. So the first one is patient-centered care. So they're not just numbers. We're being very specific about treating each individual specifically. And it also emphasizes the importance of respecting and responding to those individual patient preferences, needs, and values. Okay. So we all know that you treat patients holistically. So you should be individually treating your patients, not just looking at them like, oh, well, every heart failure is the same heart failure. No, everybody has different needs, right? So another one is teamwork and collaboration. So it definitely promotes effective communication and cooperation among the healthcare team members. So to be competent in this area, you need to have systems in place that allow for effective collaboration. So like things like SBAR. That helps saying that like we're giving effective communication handoff. Just even like the promotion of like the texting and the cell phones and pagers way back in the day that promotes the communication aspect of, interdisciplinary care. Electronic health records also kind of promote these kind of things. So then you also have evidence-based practice. And I know y'all have heard evidence-based practice. What does that mean? Gosh, I wish I could teach that course to you guys because that's like my favorite. Anyways, what evidence-based practice means is that you're not just doing something because your grandma told you to, okay? It means that we're doing this because we have found through multiple, not one, multiple studies that this has improved patient outcomes, or this has led to better this, or this is best for this kind of group of patients, or whatever the case may be. And so we're letting evidence and data drive our policies and our practices and our decision making. We're not just doing it because we feel like it or because it's, just like a whim of things. Because if we did that, then nobody would be washing their hands. Because at some point, good old Florence decided that, hey, there might be these things called like germs or like something is causing infections and people are dying. So maybe we should like clean things like our hands or like our surgical instruments. Like, yeah, that's kind of important, right? So like, don't take it for granted that what we do today always was, right? And so I'm sure we're doing tons of things right now that in the future we're going to look back on and with our heads hanging down low because we're like, why did we think that that was okay? But that's what's so cool about research. You get to like make changes for the better. Anyways, okay. So evidence-based practice, super important. Okay. Quality improvement is right off the top of evidence-based practice. And there's a difference. Research, evidence-based practice, QI, real quick. Research is generating new knowledge. It's stuff we never knew before. Evidence-based practice is taking that new knowledge and applying it in a real life scenario. Like a research is like in a lab in a controlled setting, studying if you can transfer bacteria from one hand to a surface. Oh, we decided that that works. What evidence-based practice project and that thing, what that would be was, okay, so we see that like bacteria can move from like your hand to the table. Well, but that wasn't in a controlled lab where we're controlling the air movement, the air conditioning, the blah, blah, blah. Let's see if it's in real life. Let's go test to see if we have bacteria in somebody's hand and if it will spread to the stretcher in an ER. So you're taking something that you learned in a very controlled area that was brand new knowledge that we never knew before, and we're applying it to a real world setting. That's EBP. Okay. Then after that, what is QI? You guys are probably going to be very much involved in QI projects in your new grad orientation. They're probably going to make you be a part of it, or an EBP practice project. But QI is you're taking something that's already a policy, already like we've already done the evidence-based practice to know that this works, or discovered whatever the case may be about, like we should be washing our hands right before we take care of our patients. What QI is QI was, once upon a time there was a policy that said wash your hands like before you take patients. QI was changing and making a policy better based off of practice and what you find in the literature. So QI would be, you know what, we wash our hands before we enter every single patient's room, but we haven't ever, let's just say, washed our hands again before we did a sterile procedure. So I think we need to add to our hand washing and cleanliness policy that we should be washing our hands before sterile procedures too, if that makes sense. Or it's, hey, we've just been using water to wash our hands. I think it's better to use water and soap. That's QI. So QI is taking something that we already have a policy on and changing it based off of what you read in the literature to make it and to see if it makes it better, and measuring it. So I hope that makes sense to you guys. Okay. I was like a research course in 5 seconds. Okay. Anyways, safety is also big. And I know that you guys know this. We push safety left, right, up, down, and every which way, right? So safety is one of the biggest concerns for anybody. And it's our goal to minimize those risks and harms to patients. Okay. So we should always be thinking, what could potentially happen? What's that, what are they at risk for? And we should try to like mitigate that risk as much as we can. So that would be stuff like fall precautions, or putting like armbands on a patient that they are allergic to a medication, and not just relying on a chart to say that that the patient's allergic to penicillin. We're going to also put it on their arm, so it's like trying to mitigate possible bad things happening to your patients. Okay, so then the last thing is informatics, which is, again, another one of my loves. I love technology. Anyways, so that involves using technology to manage information and also support decision-making and patient care. So this is, yes, it's EHR, but it's so much more. And you've taken a course, you know all about it. Okay, so back on the patient safety goals. So the Joint Commission, which if you ever hear of, Joint Commission's in the house, like that's basically like the hospital police. You can think of them like that. They can come in and shut down a hospital in a split second. So we don't want to make Joint Commission mad, but we also want to do good right by our patients. So if you follow Joint Commission rules and patient safety goals and guidelines, you'll be fine. Now, they change patient safety goals every year. So it's important that you stay up to date. Again, if you go into leadership management education, you will definitely know these up, down, left, right, forward, backward, and every which way in between. So very important to know about the National Patient Safety Goals. So some of them right now, so these are the 2024 Hospital National Patient Safety Goals. By the way, there's different patient safety goals depending on what area you practice in. There's like ambulatory services, there's behavioral health ones too, but I just put up general hospital because that's just kind of what we're focused on right now. So critical care nurses are super important in meeting these patient safety goals that the Joint Commission establishes each year. Okay, so the goals are designed to address the most pressing patient safety concerns that are currently out there and in practice, and promote very specific improvements in that patient care for those areas. So the key areas you can see on the screen right here, they include identifying patients correctly, and this has been around since basically National Patient Safety Goals originated. Improve staff communication, medication safety, alarms safe, use of those safely, preventing infections, identifying patient safety risks, specific to suicide, improving health care equity, and prevent mistakes in surgery. Now, you can read all these, and I would pause and read each one of these and become familiar with these. These are so important for you guys to know. You might even get asked questions about these in an interview. Like, talk to me about national patient safety goals and how you plan to incorporate them. Well, if you can speak to like a specific one on here, that shows that you're actually smart enough and you learned about them. So this is something that you need to know. You just need to know these. Okay, you don't have to memorize that. Like reducing the risk of suicide is National Patient Safety Goal 15.01.01. You don't have to know that part. You just need to know that reducing the risk of suicide is one of the National Patient Safety Goals, and that falls under identifying patient safety risks. So, utilizing evidence-based practice in critical care. Kind of already touched on this, okay, but it is, again, super important for critical care nurses, ER nurses, all nurses. So what it does is it ensures the care provided that we provide to our patients is the best that is out there based off of what is available in the evidence, okay? So the National Guideline Clearinghouse is a valuable resource that provides access to a wide range of clinical guidelines. You will also probably have access to all of the databases, research databases, all the medical journals as well when you work for any healthcare organization. I suggest you guys don't just forget your skills when you're learning how to like look up research articles, because you're going to have to do it again throughout the rest of your career. Yay. Okay. So, but utilizing those specific guidelines, in your practice as a nurse anywhere, but critical care nursing is going to help ensure that your care is standardized, it's effective, and it's up to date. Okay. Integrating EBP into your daily practice can lead to improved patient outcomes, obviously, such as reduced complications and enhanced recovery rates, and getting the patients to get home and having better outcomes makes everybody happy, right? Okay, so, but also know on the flip side, implementation can also be challenging due to factors like resistance to change, which is a big one. People like to stay in their little comfort zones, or lack of resources, which we all know there's always a constraint about money. So, like, does your organization want to buy the latest and greatest technology or the latest and greatest, medical device? It could make things better for your patients, but it may not fit the bottom dollar. So, there's some issues there, right? So you need to be aware of these strategies, be aware of these challenges, but also think of the strategies that you can to overcome those barriers. And some of those could be just education, like, hey, this is needed, but also getting the buy-in from your leadership, and also just fostering a culture in your workplace that values continuous improvement and learning. So be part of that, like always wanting to learn. That's why I like working for teaching hospitals, just FYI, because it's a cool place to work and you're always with the latest and greatest. Okay, so some strategies for effective communication in the critical care. You should know all these, but let's just review real quick. So super important to be effective in your communication, right? So be clear and be concise with your communication. This is going to reduce errors, okay? Ensure that all the team members are on the same page. So that also improves patient outcomes. What does that look like? Like, make sure that if you have a nurse tech there, that they know what's going on. Like, if there's a change, let your charge nurse know, let respiratory know, like getting everybody involved. If there's a big change in your patient or your patient status, or if there's order changes in the plan of care, we got to talk about it with everybody, right? Also, things like SBAR, you should already know about SBAR, closed loop communication during critical scenarios like codes, right? Those are widely used to structure conversations and confirm that information is accurately understood. So there's also managing difficult conversations with patients and families, particularly end-of-life situations, those ethical dilemmas, and that's going to require you to be empathetic, honest, and also just clear in your explanations. So some of the things that we talk about is like, we are very direct when a patient is dead. Like, when you have to go and talk to a family that the patient has passed away, you don't say passed away. You say the patient has died. And that's very hard for a lot of nurses that aren't used to it. And to be part of these conversations, you might be like, that's so brutal. But like, families go through denial. It's a big, big deal. So being very clear when we're talking about what is going on with our patient is so important. Don't use ambiguous terms. Be very direct. So it's not like, oh, well, we're just going to talk about like an ease and transition into the afterlife. Well, what does that even mean? Like, we're going to talk about making your loved one as comfortable as possible before their death, because their death is going to be happening soon. It's a gift to families to let them know reality, what is happening. You want them to be able to make the best decisions for themselves and their families, but they can't make those if they don't know everything that's going on. So being open and clear and making sure that they understand is so important. Okay. Also, just being accurate and thorough in your documentation, because providing handoff to the next nurse, so important, so that they can see if there's been changes, truly see when the patient starts having different fluctuations in some of their vital signs or whatever the case may be. If you don't accurately assess and document, then the person that comes on the next shift isn't going to know if there's really been changes. So you've got to be accurate. And that includes being accurate on the time that it happened, not just that it happened. Because 30 minutes ago versus 3 hours ago is a big difference. Okay. Anyways, so just promoting communication, big, super important thing. So also building a culture of safety. Okay. What does that even mean? How do you even do this? Okay. This is where it's important. And you will hear the term just culture in a lot of organizations. And I don't know if you guys know what just culture means. What just culture means is that we're just. We're not just going to come after you and fire you. Well, I mean, people can, but for just like a mistake. We want you to be open and honest when you make a mistake, because if you hide it, that is so much worse than anything else. And they a lot of times do not have disciplinary action if you self-report. And so that's a just culture, is a culture and an environment where we try to see the root cause. And I will tell you guys, when I was in leadership, I was taught many, many things. And one of the things that stuck with me, and I truly believe it, and I want you guys to remember this, when somebody messes up and there's a patient, like a med error or something, it is so rare, so rare, it does happen, that it's because somebody is just a horrible human being, okay? And they wanted to hurt somebody. And it's actually rare that it was just because they were like lazy or something. The majority of the time that there is a issue, like a patient safety issue, like they got the wrong med or something happened to the patient, it is because there was something there for two reasons: either a lack of resources or a lack of education. Okay, so like the nurse didn't know any better. Okay, so we can solve that by educating them and then making sure the unit, right? Like then it's not going to happen again. Like they just didn't know, like they've never taken care of that before, whatever the case may be. The other one is like the lack of resources, and that includes a policy. So there may be a policy, and the way it's written leads to a medication error, and there was no way to avoid it. Okay, so if that's the case, then we need to look at revising the policy. Both of these, education or like policy or resources, you shouldn't be punishing the nurse for that error. Yes, we need to talk to them. We need to offer them support, but like it's not because they're just some horrible person. So that's a just culture. So that's that promoting non-punitive environment, just culture. It is big in the hospitals. That's not to say that you won't get in trouble if you make an error, but they try not to. Okay. So the big thing is like, you want to be part of that you are willing to be open and honest when you make a mess up. And it's important that you actually document near misses. Near misses is, I almost did a med error, but I caught myself right beforehand. Well, if you don't document that, then somebody else is going to come along and probably have the same thing, but that one might actually lead to an actual medication error or something that goes wrong with the patient. If you had documented your near miss and exposed like a policy issue or like even just your lack of understanding, then we may have been able to identify, oh, we need to go train everybody. Nobody knows that this is the way that we're supposed to be doing things. Yeah, or we need to change this policy because we're just lucky nobody's died yet. We need to change this before somebody actually dies, that kind of thing. So like that's why it's important to be to actually even do near misses. Super important. So you already know about technology and the ER and ICU, but you can read the page. It's not a whole bunch. It's important. Okay, so it brings challenges as well as it helps us. Okay. So just know that it's important and we need to keep up to date with things. And technology is always advancing, just like medicine. So stay up to date. So that challenge question number 1, pause it, think about it. Did you change your mind? Okay. So critical care nurse and the patient who's just been admitted to the ICU, severe sepsis. What is part of the Joint Commission's National Patient Safety Goals? If you said B, you are correct. Okay. So medication reconciliation is a critical, important safety measure that helps prevent medication errors, which are common issues in the critical care settings. Oh, yes. The Joint Commission Safety Goals emphasizes the importance of accurately and completely reconciling medications across the continuum of care. This is, what do you take at home? What have you been prescribed? Are you currently taking it? When did you take it last? All that kind of stuff, okay? So while other options are important, like the A, the C, and the D, okay, that MedRec is definitely and directly addressed in the patient safety goals. You just had to know it. Challenge question number 2, patient in the ICU has a DNR order and the family is requesting that all life-sustaining treatments be continued, including mechanical ventilation. What is the critical nurse's best response in this situation? Read A, B, C, D. Think about your answer. We'll get back to it, but go ahead and pause and make your selection. Okay, let's move on. So the code of ethics for nurses and the applications of that in critical care. So now let's talk about some ethics. Again, I'm hoping that you guys have crossed and discussed some of these before, but if not, let's talk about some of them. So code of ethics is a foundational document that outlines the ethical obligations and duties of every nurse, including those in the critical care. Its purpose is to guide nurses in the practice, ensuring that they uphold the highest standards and ethics. Okay, so it definitely promotes autonomy, confidentiality, and the commitment to provide care without bias. This is so hard to do. I'm just going to be honest with you. We all have biases. To say you don't is a lie. You might get a patient in that looks like your ex-boyfriend or your ex-girlfriend. It's kind of like you take a double take, but you're like, oh, they're not my ex-boyfriend, girlfriend. You retreat them with care. There are so many triggers. It might be a patient that acts just like a ex-friend or something, or somebody that did somebody wrong. And I've taken care of so many people that were murderers. Okay, like we all have a bias against murderers, I would think. Like you think that they're not the most, sanctified people on the planet, but and if they killed somebody else, they could kill me, there might be a little apprehension taking care of them. But ultimately, we have to treat everybody as best we can the same. Everybody is a human being. Everybody deserves dignity. Everybody deserves compassion. Everybody deserves care. So we're going to talk a little bit more about this in class, but this is definitely something you guys need to start thinking about. If you haven't thought about it, you need to think about what those biases are before you get exposed and in front of a situation where you haven't thought it through yet. Okay. I know we kind of touched on this in the first few weeks of the course, but you really need to start thinking about some of these ethical dilemmas. Okay. It's also important for you to be able to support your patient. Your patient might be making decisions, or the family, that you absolutely would never make, and you disagree wholeheartedly, but it is not your job to tell them what to do. It's your job to support them in their decisions. Okay. So ethical decision-making is a complex process that's going to require each one of you guys to balance multiple factors, including patient preferences, clinical evidence, and ethical principles. So some of those key components of ethical decision-making include identifying the ethical issue that is even present, like even realizing you're in an ethical decision-making scenario. Then you need to consider all perspectives, not just yours, obviously, but the patient might have a different one than you, but the family might even have a different one, and the physician. You might have 4 different perspectives. So consider everything, okay? Try to be empathetic. Put yourself in those shoes, okay? You also need to evaluate the potential outcomes of the different courses of action, the different choices you have, okay? Like what could happen. And you might be in a situation where you feel like there's a no-win. That happens a lot. So you need to be prepared for that. So there are some different organizations have different ways of dealing with ethical decision-making. A lot of times there are if it's something that doesn't require immediate decisions, there's ethics committees you can present something to. So like it's a policy or something that is an ethical decision that we have to talk about. But there's typically a lot of them have ethics hotlines. Your risk management person, the risk management person is the person that goes around looking for ways that somebody might mess up, and they're trying to mitigate those risks. Okay, that's your risk management person. Risk management also knows a whole lot about ethics, and a lot of times they're on call 24/7 or present, and you can always call them to help you think through all those different possibilities. Everything from like what's the best decision, but also how does that affect, like legally, how does that affect everybody? Risk management's really great about that. Okay, so core ethical principles in the practice, a little bit more. So these are on the screen, you're going to see some definitions. I suggest you know all these definitions if you don't already know them, and know how to apply them. Okay, so don't just memorize, autonomy is respecting the patient's right to make their own decisions. Okay, what does that look like? That looks like a patient deciding that they no longer want to receive cancer treatment, and they just want to let nature take its course and go home and spend time with their family in the time they have left. Okay, you might disagree with it, but again, the patient has autonomy. They have the ability to make their own decisions. Okay, does that make sense? Okay, so know all these definitions and know how to apply them. Okay, so understanding and managing moral distress. You are going to have moral distress. It is a way of life in the nursing field. Okay, when does this happen? It happens when nurses are unable to act according to their own ethical beliefs due to various things like constraints of a policy that, like, of the place that you work. The policy says do something, but ethically you're like, that goes against everything I believe in. Maybe it might be a lack of resources. Like, you want to do what's best for this patient. You feel like this is best, but you don't have the resources, whether that's physical, like supplies, or other care team members. It might be that you want to sit there and hold the hand of your dying patient, but you have 50 other patients you've got to go see and you don't have the time. Okay. Like, that's a moral distress. Think about the COVID nurses that they were not, like, they'd have to suit up and go in there, and they were seeing their patients die all alone. Like, and you just wanted to let their family members in there, like the family member didn't care, but there was a policy. Nobody was allowed in the hospital. Like this, like, that's moral distress, definitely. Okay, so specific to the critical care setting, some of those the more common causes of moral distress are going to include situations where the nurse feels that, like, an aggressive treatment is not in the best interest of the patient, or when there's like a lack of alignment between the healthcare team and the family's wishes. Those are some of the more common things where you're going to be kind of stuck with, what do I do? So it's important that you have coping strategies to deal with these situations, because you might end up doing something that just inherently feels wrong, but it's right for the patient, or it is the best that you can do with what you have at your fingertips. So some suggestions for some coping strategies would be like seeking support from your colleagues, talking it over with the nurse next to you, your charge nurse. Also, the ethics committee, seeking them out, seeing like what is available, what can we do with this situation. And also just being open with the charge nurse, your leadership, your management, like, this is really bothering me. Now, like, so for me, example, and I've told many people about this, taking care of a patient that just recently killed a police officer, like deliberately killed a police officer. Like, you guys know that my husband is in law enforcement, and that's very hard for me. Can I do it? Yes. Do I want to do it? No, I would rather somebody else take care of that person. I know that it's very hard for me to emotionally separate it, especially if it's somebody that I knew. And it's happened before where I've taken care of somebody that killed somebody that I knew. Okay. Very hard. So I just let my leadership know, like, hey, can you help me out? Let's switch patients with somebody else. And thank you. Like, thank you. Like, because I don't want to do wrong by somebody, because that's still a human being. Right. But like, it's gonna take me time to process. It's gonna take me time to think through, and it just would be easier and better for everybody involved at that moment in time if somebody else takes care of this person and I go over here and take care of somebody else. If that makes sense. So those are some of the things that you can do if you're in those situations. So specifics to those ethics committees, kind of talked about this already. What they do, they serve as a valuable resource to the whole hospital, but especially they get involved in the critical care setting a lot more often than you would think, or maybe you would think. I don't know. So what they do is they provide guidance and support in navigating those complex ethical dilemmas. Okay. So the committees are typically made up of healthcare professionals from different disciplines. And nurses are on there, medicine, social work, chaplains are on ethics committees. And a lot of times they actually have community representatives as well. It's not just people in your hospital system. Okay. So the committees can be consulted when there's conflicts between patients, families, and the healthcare team, or a mixture of those, or just actually anytime that you're just uncertain about what the best course of action is going to be to ethically provide care to your patients. Okay. So as a critical care nurse, we can seek the guidance of ethics committees, or we can actually actively participate in them. If this is something that you're interested in, like reach out, ask how you can join and be part of it. Okay. The benefits of ethics consultations include facilitating open dialogue. They help, they're kind of like a neutral third party. They can sometimes come in and clarify values and goals from the different parties involved and help actually reach a consensus and a conclusion. It's kind of like a counselor, like they kind of come in and it's very holistic. Okay. But ultimately, their goal is supporting the best interests of everybody, including patients, families, and the healthcare team. So end of life care in the critical care setting, it's part of being a nurse, but it's definitely part of being a critical care nurse. So end of life care is a sensitive, but again, important part of critical care nursing. And it's going to require a compassionate approach that honors the dignity and preference of the patients and their families. This is where you have to take your opinions out, okay? The primary goal of end-of-life care includes managing pain and symptoms, also providing emotional and spiritual support, and facilitating that clear communication to help patients and their families make those informed decisions. Just like I said, how can they, if they don't know they only have an hour left, they might go out for lunch and then they come back and they don't have any time left, and their family member has passed on. So like, you need to be honest with them about what's going on, compassionately honest, okay? So as an ICU nurse, as an ER nurse, this is so important for you guys to understand. Okay. As a brand new nurse, are you going to be the one leading these conversations? Absolutely not. But are you going to be caring for patients in the end of life? Yes, you will. You will be hopefully you have a great team that supports you. Your charge nurse steps in, your preceptor steps in, and they hold your hand until you get some experience. But this is definitely something that's hard for everybody at first. Okay. So family conferences are one of the things that really, really help everybody involved. Okay. So you see this a lot in the ICU. They will conduct a family conference either in person or over the phone. They prefer in person if it's really like negative news that they want to make sure that like the family is going to be supported. They want them there before they relay it. But sometimes that's just not possible. What if the family's across the country? Like, we got to talk, right? So we will do family conferences and bring everybody together. And this is where we will have multiple members from the healthcare team, including like chaplains, nurses, the physicians. That sometimes it's the whole team, and we're coming in. A lot of times, the physician will be the one that actually guides the conference, but we let the families ask questions. We definitely tell them what's going on, and we talk about their options. Just know that the first few family conferences very rarely end in anything other than just communication and updating decisions. It's very common for if a decision needs to be made, it normally takes families time, okay, to come to terms or to just even realize what's going on. I mean, it's not always the case, but just know that when you work in the ICU, you definitely have meetings a lot. So do not resuscitate orders, DNR. There's people call these different things. Okay. There's DNR is the old school term, and different hospitals have different wording for it, but they're all similar, but you need to follow your policy as far as which one you're going to call. What a DNR is it's a directive that instructs healthcare providers not to perform CPR. Okay. So cardiopulmonary resuscitation, if a patient's heart stops or they stop breathing. The purpose of it is to respect that patient's wishes, to avoid aggressive interventions that may not align with their goals of end of life care or just for quality of life in general. So, obtaining a DNR order typically involves discussion between the patient or like their legal decision maker and the healthcare team, and in some cases, ethics committees. It's important to differentiate between withholding and withdrawing life support. Withholding means not starting it, while withdrawing means stopping a treatment that's already been initiated. Okay. So both decisions are ethically and legally acceptable, and especially in the state of Texas, when it's aligned with the patient's preferences. Okay. So as a critical care nurse, our role includes facilitating these discussions. Okay. Don't be afraid to talk about it. Okay. But like again, ask for help when it's the first time. Providing education support to both patients and the families, but also you need to advocate for the patient's wishes, especially if you had a chance to talk to the patient, okay? Like, and you know their wishes, you need to help support them. Sometimes that's just letting them talk to you after their family leaves. They just need somebody to talk to and express how they feel about things, you know? And remember, as a nurse, you have all the time in the world. And advocate, but you also need to make sure that whatever you do, you are patient-centered and you're respectful of your patient's choices. Okay. So, very important. DNRs, we're going to talk a little bit more about these in class, because I know you guys probably have some questions about these. If you have a question about anything legally speaking, please post it in the discussion board questions so I can answer it, for everybody. Cause I know you guys always have, every year students have questions about these. So, Patient Self-Determination Act and Advance Directives. What are these? A lot of people mix these things up when they're talking, and they don't really know the difference. It's kind of like knowing the difference between a protective order and a restraining order. Nobody ever knows the difference between those. And there's a big difference, and everybody always says the wrong one. But anyways, okay. So the Patient Self-Determination Act is a federal law that encourages patients to make decisions about their own health care, including the right to accept or refuse medical treatment. Okay. Advance directives are legal documents that allow patients to outline their preferences for care in advance, ensuring that their wishes are respected, even if they're unable to communicate with them. Okay. So common types of advance directives include living wills, which specify the type of medical treatment a patient would or would not want. Okay. Now, a durable power of attorney for healthcare. What that does is it designates somebody to make the healthcare decisions on the patient's behalf. Okay. A healthcare surrogate who is appointed sometimes by like the court to make decisions for a patient when a patient can't. Okay. So those are three different ways for decisions to be made for patients on their medical care when the patient isn't able to speak for themselves. There's a living will, a power of attorney, and a healthcare surrogate. Okay. Now, which one trumps which one in which situation? It's all different. What's funny is it's not funny, actually. Sorry, not funny at all. What's sad? What's really sad is often you will have a child and a parent disagree about end of life decisions, and the parent is still awake and alert, able to make decisions. They're oriented, and the child says, well, I have a medical power of attorney, so I want you to do X, Y, Z. No. That thing only goes into effect when the patient isn't capable of responding, whether that means that they're like comatose or they're not coherent, they're not oriented, like they don't know they don't even know their name, they're not capable of doing it. That's only when that one goes into effect. And I see it all. Like it happens all the time. People think they can make decisions. Like, no, they're still alive and they still can make their own decisions. It goes to the patient. Okay. So as a nurse, it is our responsibility to educate patients and families about these options, assist in the completion of these documents. Now, you're not going to be the ones filling them out. I shouldn't say always, but most of the time, 99% of the time, your hospital has somebody that can come and help them fill it out. A lot of times it's chaplain too. So upon admission, you always ask if patients have living wills, DNRs, or anything like that, and did they bring it with them? Because if they didn't bring it with them, it doesn't matter. If I can't see it, I don't care that it's at home attached to your refrigerator. Sorry, I got to see it. Anyways, so you can talk about it, and if they want to do one, and create one, you can call the different person, whoever your hospital has set up to help the patients and families with that, and they will come in and do it for you, but you're the one that can facilitate and get the ball rolling on that. Okay. So, super important that we talk to our patients about that. Okay. And it's super important also that our patients' preferences are just clearly documented and accessible in the medical record. If they have a living will or a power of attorney or something, we want it ASAP, get it up here, and let's attach it to the chart so that everybody can see it and everybody can know who's making what decisions, and, so that we can follow the patient's preferences. Okay. So now, palliative care versus hospice care. What is the difference? Okay. They're both approaches that focus on improving the quality of life for patients with serious illnesses, but they do differ in a few ways. So palliative care can be provided at any stage of a serious illness, and it's not limited to those at the end of life, okay? Its primary goal is to alleviate symptoms, manage pain, and provide support to patients and families, regardless of the prognosis, okay? This is somebody that has like congestive heart failure. They can't even walk up a flight of stairs. They're always in pain, sort of issues, fluid overload, but they've managed it well enough where like their life expectancy maybe is 10 years from now. They can get on palliative care. Okay. Now versus hospice. Well, even hospice you can get on. It's not like imminent, but hospice means that they have something that will eventually lead to their death, like a diagnosis. But hospice is specifically for those patients who are nearing end of life. So depending on and this is insurance company designates if you're on hospice versus palliative, by the way. It's not us that decides, but hospice care emphasizes comfort and quality of life. So if they qualify for hospice, insurance will now pay for XYZ, pay for at-home care, pay for, treatments and different things. It also opens up what the providers feel safe about prescribing. Like they'll prescribe heavier doses of like narcotics for pain because we know we're nearing end of life, and we want to provide comfort, right, to those patients. So hospice, hospice care is emphasizing comfort and quality often we're not trying to cure anymore. Okay. Palliative, you could be still trying to cure technically. So as critical care nurses, it's your role in palliative and hospice care to include assessing the patient's needs, managing symptoms, and providing education and support. Okay. It's also coordinating with interdisciplinary teams to ensure that the care is going to align with the patient's goals and preferences. Okay. This is going to be another little soapbox moment. You guys are young. Okay. So you're thinking that this is never going to happen to you, but I highly encourage you guys to have these talks with your parents. Have these talks with if you have a significant other, you need to have these talks. You need to have a living will. I don't care. You are old enough to know what your wishes are. And your wishes may change, and that's fine. In the future, you can change your document, but you need to have a living will. You know what that is? That is a gift to your family, to your loved ones. A living will takes the guilt away from them in making those decisions, okay? I'm just going to, get on a personal note. During the birth of my third child, I literally basically was told I had a 50-50 shot at surviving the next 24 hours when I got my head bleed, my subdural. I had discussions with my husband, but I had not updated my living will since I was in nursing school, and things had changed in what my wishes were. I had to have massive, serious conversations with him real quick. And it was not the time. I did not want to spend time telling him what my wishes were. But I also, you need to have conversations. I had to have conversations with him about not just medical care, like how I wanted him to go about life. I wanted him to find love again. Like, if I don't make it, I want you to do this. I also had to have a talk with him about if my body still lives, what I wanted, like if I was like in a comatose state for the rest of my life, it could have happened. I didn't have that in my living will. I only had I was like what to do about more like resuscitate, not resuscitate. There was so much in it, y'all. It was horrible. Of course, we've had those conversations. We've updated things now. Like, I should have known better. I preach this to you guys every year. Have these conversations. And and it may take multiple conversations to actually reach to a point, but start having these conversations now. Trust me, start having them. Okay. And when you get married and have kids, my goodness, do it. Please just take it from me. Just do it. Okay, so enhancing communication at the end of life. Okay. Communication, like I've said before, so important, so important, right? So it's going to directly impact the patient and the family's experience. Your communication technique, the way that you're communicating, how often you're communicating, can lead to traumas, or it can prevent traumas. Okay. So you need to be clear and compassionate when you're communicating. Okay. That's going to help ensure that the patients and their families understand the prognosis. They understand all of their treatment options, and they also understand what to expect as that illness is progressing. Okay. Giving them a heads up, again, that will help prevent traumas. It won't necessarily prevent all of them, but it will help mitigate it at least. So techniques such as using plain language, like we already talked about, just actively listening, again, we already talked about, and providing information in manageable amounts. Don't just throw it all at once, okay? That's what's going to help make the complex information more accessible and more easy for patients and their families to digest and think on and make decisions, okay? It's also important to approach those difficult conversations with sensitivity. You need to acknowledge that emotions and fears that the patients and families might have, okay? Just be prepared before you even go in. Involve patients and families in the decision making, okay? That's going to empower them to make an informed choice that aligns with their values and goals. Remember, it's theirs, not yours. Additionally, you guys document their care preferences and communicate it to the entire healthcare team. That is so important so that you can ensure that care is consistent even when you're not at work, okay? That no matter who's there taking care of your patient, their wishes are going to be honored, okay? So as a critical care nurse, you have a unique opportunity to support patients and families through these conversations, okay? So just remember to be clear, focus on comfort, focus on compassion, but also focus on guidance for the family and advocacy for the family. Okay. Kind of switching gears, but kind of staying on the same topic. Withholding or withdrawing treatment in euthanasia. Okay. We have to talk about this. I want to preface this with, we are a Catholic university and a Catholic institution. We do not believe in euthanasia. We do not support it at all. Okay. If you would like to talk more about the ethical dilemmas of that, I would highly encourage you guys to reach out to your priest, pastor, whoever you seek guidance for spiritually. But I just have to preface with, as a Catholic institution, we do not promote euthanasia, but we need to talk about it because you might encounter it as a nurse. Okay. So what's the difference? Withholding or withdrawing treatment and euthanasia, they're all very different, distinct concepts, okay? And they're often misunderstood. So withholding treatment refers to not initiating a medical intervention, versus withdrawing treatment involves stopping an intervention that's already begun. Both of those practices are considered ethically acceptable when they align with the patient's wishes and are done with informed consent. Now, euthanasia, okay, what that is it involves actively ending a patient's life. Typically, people say and use their rationales to relieve suffering, okay? It is illegal in most jurisdictions, okay? There are some states that allow it. There are some countries that allow it, but most places it's illegal, okay? So now the key difference lies in the intent. Withholding and withdrawing treatment respects the natural course of the illness, like what nature would naturally do if medicine wasn't, here, right? Like if just what naturally would happen, okay? Versus euthanasia, which it's a direct action to cause death. Like we are actually helping death happen. That would not have happened otherwise, okay? As a critical care nurse, it's your duty to support patients and their family in making informed decisions about their care, okay? Ensuring that we respect their autonomy while adhering to legal and ethical standards, okay? Maintaining ethical integrity in your practice involves staying true to our professional values and advocating for our patients' rights and providing compassionate care that honors their wishes. So now, 2 common meds that we use at end of life, morphine and benzodiazepines, okay? So benzos, remember that's synthetic alcohol, but things like Ativan, lorazepam, those kind of things, okay? They're commonly used to manage the symptoms such as pain, dyspnea, and anxiety. Okay, morphine, which we all know is an opioid analgesic, it works by binding to the opioid receptors in the brain and the spinal cord. Okay, what that does is it reduces the perception of pain in the brain to improve the comfort of the patient. It can also help relieve breathlessness by reducing the sensation of air hunger. It makes people feel like they can't breathe. It kind of takes away that like anxiety of like needing air. Okay, but it does decrease the respiratory drive too. Okay, so benzos such as lorazepam, midazolam, those are used as sedatives and for the anxiolytic effect. So anxiolysis, anxiolytic, basically reducing anxiety. So those medications can be administered multiple routes, like oral, sublingual, IV, subcutaneous, and even intranasally. Okay. So when you use these medications, it's important for you guys to monitor their effectiveness. Okay. And you a lot of times will have orders to be able to adjust or titrate doses as needed to achieve the symptom control. So to achieve a pain level of less than 3 or whatever the case may be. Okay. But you also need to be trying to minimize those side effects. Okay. So the common concerns for these meds include the potential for sedation or respiratory depression. However, when you use it appropriately, these medications can just enhance the quality of life for our patients at the end of life, which is going to provide much needed relief from distressing symptoms. And oftentimes those symptoms are visible. And so it also is going to help the family members know that their loved one wasn't suffering in the end. So family conferences, we already kind of talked about these. You can pause, read the screen. There's not much more to add, but I just want to reiterate that it's important to create a supportive environment in family conferences where those family members feel comfortable to ask questions and also express their emotions. Like this is like a free, safe zone. Okay. No judgment. Ask any question you have. We're here for you. Like, tell me how you're feeling, open-ended questions. Like I have all the time in the world kind of approach. Okay. So emotional support is the thing that is so, so, so important. Okay. So the families are going to be experiencing all ranges of emotions. They could be mad. They could be angry. They could be sad. They could be happy. They could be relieved. They could be fearful. There's so many different things. Okay. So expect them all. So when you're a nurse, you're going to facilitate these conferences. Okay. Critical care nurses are definitely involved. Okay. Often ICU nurses are more involved than ER nurses because they're so quick in and out of the ER, but these do happen in the ER too. Okay. So you just want to make sure you're supporting the family through the process. So some of the holistic interventions that we can do at end of life. Okay. They are going to not only meet the physical, but also the emotional, spiritual, and psychological needs. Okay. So physical care involves managing the pain and the discomfort and those kind of things, right? So remember, that's going to be like administering meds, repositioning the patient to relieve discomfort, ensuring that they get their basic needs, hydration, hygiene, those kind of things, right? Now, the emotional and spiritual support is just as important. Okay. And those things are going to be just like listening to the patient, offering a listening ear, providing reassurance, facilitating access to spiritual care providers. They might attend a specific church or religious service, getting their personal pastor, priest into the hospital, like facilitating, calling them up, getting them in. That's great. But even just calling our chaplain there to come and pray with them, that's great too. Those kind of things. Also facilitating or just being present. Also, maybe they just need to see a loved one. They also might ask you to make a phone call for them because there's somebody they haven't spoken to in 12 years and they really want you to help talk to this person. And you might have to be the one like, hi, my name is nurse so-and-so. I'm calling on the behalf of patient so-and-so, and they're here with me, and they wanted me to ask if you'd be willing to have a conversation with them. And that might be what you're asked to do. And it's okay as long as you have permission. Okay. You just make sure you have permission. You don't do these without the permission of the patient. But these are definitely things that happen at end of life that you need to be prepared for. There's also complementary therapies like aromatherapy, music therapy, massage, those kind of things that you can integrate into their care that just adds to the comfort. Okay. So remember, we're nurses and we're holistic and we look at the whole person, not just the medical issues. So again, the psychological, spiritual, and emotional support, We already kind of talked about these. Just make sure that you're collaborating with as many people as possible, but you're also taking care of the family, not just the patient, because this is affecting everybody. So debriefing for nurses. This is something we do not do enough. Providing that end of life care can be so emotionally taxing on nurses. Also just dealing with codes, just end of life in general, not just like anticipated end of life, but just end of life in general. Debriefing is such a valuable process that allows nurses just to talk, reflect, share their experiences. I will tell you that we're horrible about doing this in adult facilities, but they're so much better about doing these in pediatric facilities. In the pediatric ER, traumatic pediatric deaths, almost every single time, as soon as we kind of wrapped things up, caring for the body of a pediatric patient, everybody would be like, everybody that was involved in the code or whatever the case may be, everybody would be like, go to the break room. And we'd all go to the break room, and we would just, it wasn't formal or anything like that, but it was just like, are y'all doing okay? You doing okay? We're checking in on each other, and somebody will make a note. Did you see this? Yeah, I saw that. Oh my God, I can't believe. And we just kind of just talk it out, because you need to talk it out. If you don't talk it out, you don't realize, the way I explain it is like, sometimes these little bitty teeny tiny traumas to us, what you're doing is you're just chipping little pieces off of your soul as a nurse. And I know that's kind of, I hope that's not morbid to say that like that, but like, if you don't have self-care and you don't debrief, you don't talk about things, a lot of times nurses, we're so goal focused. We're so, compartmentalize it. We just wrap it up in a little box and put the box to the side, but the box never goes away. And eventually we have a whole bunch of boxes with these like little bitty like traumas, like from the deaths of patients and all this kind of stuff. And it just wears on your soul after time. So you guys need to have self-care practice. You need to figure out what is something that feeds your soul, feeds your mind. It might be exercise, it might be going for a run. It might be reading a book. It might be hanging out with friends. It might be going on vacations. You need to figure out what you need to do, and you need to schedule it in your life so that you are feeding yourself and so that you don't lead to compassion fatigue or burnout. It is so, so, so important. Every healthcare organization has like peer assistance programs. Do not be afraid to reach out to them. Do not be afraid to reach out and go to therapy, counseling. Seek advice from your priest, your pastor, your a trusted mentor. Like you guys need to definitely not neglect yourselves. So that challenge question number 2, patient in the ICU has a DNR. The family is requesting that we continue everything. Okay. What, as a critical care nurse, is your best response? So pause, read it again, make your decision. If you said C, you're correct. Okay. Explain the implications of the DNR order and involve the ethics committee for future guidance. Why is it C? Okay. So the rationale is when there's a conflict between the patient's DNR order and the family's request, it is so important to clarify the intent and implications of the DNR order with the family. The nurse should facilitate a discussion to ensure that the family's understanding aligns with the patient's wishes. Involving the ethics committee provides additional support and guidance, which is going to help to mediate and mitigate the conflict, okay? And it will also help reach a resolution that respects the patient's rights and ethical standards in critical care. Respecting the DNR order while engaging in the family and understanding and the decision is important, rather than automatically complying with the family's request or making unilateral decisions, okay? So like A, we don't want to just disregard the patient's like wishes, okay? So we wouldn't do A. B, discontinue life-sustaining treatment immediately in accordance with DNR order. Well, that's not taking into the family's thing. Legally, could we do it? If we verified the DNR, we could, but is it the right thing? No. C, explain it and involve the ethics committee. Yes, because I can guarantee you that ethics committee is also going to look at the legality of it and ensure the DNR is legit and that it can be implemented. But yes, it does take time. So you're going to have to resuscitate them until this can be convened. But that is the best choice. But let's talk about D2. Contact the PCP to have the DNR order rescinded per the family's request. Absolutely not. You would never go against the patients like behind their back on that. So the best answer for this is C. Okay, so a review and some key takeaways for Module 4. So let's remember, critical care nursing is dynamic and it's challenging, okay? And it involves navigating complex ethical and legal responsibilities. Professional organizations such as AACN and ENA offer valuable guidance, resources, and opportunities for certification, which you should all do. Okay, so remember to have collaborative partnerships with other healthcare team members, and that's going to help improve patient outcomes and foster a supportive work environment and promote safety. Also, always remember to apply ethical principles such as autonomy, beneficence, and non-maleficence, which those are all important when you face those difficult decisions, particularly in end-of-life care. Effective communication is so important. Also, promoting a culture of safety is also important. And yeah, that's good. Finally, okay, as a critical care nurse, your role is ultimately advocating and caring for your patients' rights, okay? But you don't forget to support the families and provide holistic care that cannot be, the importance of that cannot be overstated, basically. Your decision to these principles will make a significant difference in the lives of your patients and their families. Okay, that is the end of Module 4. Thank you for listening. Don't forget to review the readings, assignments, and the learning objectives before we have our lecture next week. And there will be a quiz on this module in Blackboard.